disease disparities breakout. Hopefully we're on the right place. But if not, we're still welcoming you here. It's going to be good stuff no matter what. My name is Tung Nguyen. I'm going to be the moderator. And Brian, say hi as the support staff.
Yeah, hey, I've been the person behind the emails that, so thanks everyone for your patience, and thanks for being here.
Okay, I want to ask everyone to drop your intro in the chat just to save time. Name, position, pronouns, and whatever else you want to tell us about yourself. We're going to get right into the presentation. We have 7 presenters. We have 50 minutes, maybe less after I'm done here. So I'm going to ask everyone to be very respectful and go keep to your 5 minutes. I'm going to give you a 1-minute warning at the end, at the 4-minute mark. And so wherever you are then, try to finish your results and get to your conclusion, okay? It's okay to skip things if you're not ready, but you don't want to miss your results and your conclusions. And then afterwards, we'll answer some questions. Hopefully we'll have time. If you have questions for the presenters, just drop it in the chat again, and then we'll either get to it orally or the presenter can address it by chat. All right, people are coming in still. Great. Just FYI, just drop, if you're just coming in after I just said something, just introduce yourself in the chat. All right, we're going to get started. So we're going to start it. Let me see if Victor's on. Is Victor on?
Sir.
Okay, so Victor, I'm going to apologize if I mess your name up. Victor Chui, going to present on influence of diabetes on referral access and utilization of physical therapy.
Do I need to share the slide or just?
I'll share it for you. I'll share it for all the presenters.
Okay, that's awesome. Cool. I guess I'll switch to pop up.
Can you all see this okay?
Yes.
Okay. Ready when you are, Victor.
Hi, everybody. So you saw my intro in the chat. So this project is on the influence of diabetes on referral access and utilization of physical therapy. So we're in the physical therapy department. I probably don't need to tell anybody here about the growing prevalence of diabetes in the world. We're going from 530 million people, expected to hit 780 million by 2045. We know diabetes has the potential to negatively impact every tissue that's important for maintaining optimal function, integumentary, nervous, pulmonary, cardiovascular, endocrine systems, more specifically, orthopedic conditions that are common to the outpatient physical therapy setting, indicative of our negative impact on the musculoskeletal system. We have previous research that's shown, the higher incidences in persons with diabetes with respect to upper extremity and lower extremity pain. People with diabetes, when they come in physical therapy, half of them presenting with shoulder and neck pain, 60% low back pain, 71% arm, hand, knee, or hip pain. So it's clear that metabolic dysfunctions obviously leave people with diabetes at higher risk for developing these pain impairments. Therefore, if we flip it around the other way, so then the people who are pursuing physical therapy for those pain impairments often have this secondary diagnosis of diabetes or the risk factors of diabetes. But that fact is, in particular in physical therapy, goes a bit unrecognized or maybe underappreciated is the better word. And that obviously has considerable downstream implications. Their appropriate therapeutic intervention, appropriate exercise prescription, the physical activity guidance, all obviously going to be influenced by diabetes status. And where our study comes in is more from a characterization angle. So wanting to determine the prevalence of adults diabetes in our outpatient PT setting and determine any differences in demographics, health status, and healthcare utilization between patients with and without diabetes. We had a retrospective study using our de-identified electronic medical records, data from all our adults, so 18 years up, patients from our 3 UCSF physical therapy outpatient clinics. This is data from between 2016 to 2020, and these are all constrained to our SF residents. We focused on outcomes of interest that are kind of organized into 3 categories. So demographics, health status, and healthcare utilization. our demographics broke down into things, like sex, age, race, ethnicity, insurance type, distance from their home to the clinic that they went to, and also measure called area deprivation index, kind of a metric of socioeconomic kind of disadvantage, includes things like income and education, employment, housing quality, and kind of compares it on a state level. Our health status outcomes, Charleston Comorbidity Index, basically a weighted score of the comorbidities they have, as well as a broad categorization of their diagnosis type they're coming in. What are they coming in for? An orthopedic diagnosis, neuro, pelvic, or other. And then healthcare utilization, so number of visits, number of cancellations or no-shows, time to physical therapy access, so the time from referral to scheduling, from scheduling to first visit, and then the total time that took, as well as keeping account of future physical therapy episodes. So do they have any following kind of separate encounters in that same time period? And we compared the groups. And so that brings us to the more important results. This altogether was a little over 11,000 people, so 11,423 people. About 60% were female. Patients with diabetes made up 8% of that total cohort, so 900 people on the dot. The persons with diabetes cohort were older, had a worse area deprivation index, a higher proportion of males, non-whites, thank you, non-Hispanics, non-commercial insurance, all compared to those patients without diabetes. Also had higher, unexpected higher comorbidity index scores, higher prevalence of orthopedic and neurological diagnoses, and also had slightly longer access, time to access, and a higher incidence of future clinic encounters. So to wrap up, person with diabetes, they're making up a significant amount of our visits. We see we're having demographic differences and some slight differences in utilization. And so what we have here in this study is, what we think, starting place, the foundation for this future research to really understand these interrelationships between health and social and physical environments, and really shining a light for our physical therapists on making sure they understand the implications of the diabetes status on their proper management of whatever condition they're coming in for. So I'll leave
Thank
it at that.
you. Thank you very much. Thank you. All right. Well, feel free to drop your question for Victor in the chat. Next presenter is Matthew Dursensfeld. I apologize again if I mispronounced the name. Evaluation of ischemic cardiomyopathy after diagnosis and mortality.
Good morning, everyone. I'll wait a moment for my poster to get up. Okay, there it is. You may or may not know, but heart failure is incredibly common, one of the most common diagnoses in older adults, and there's a lot of health disparities within heart failure. So one of the specific things we were interested in looking at is whether there are disparities in testing for ischemic cardiomyopathy, which is the most common cause of heart failure after heart failure diagnosis. So we looked specifically at all of the patients diagnosed with heart failure within the San Francisco Health Network over the last 20 years or so, from 2001 to 2019. So our first thing was just to kind of establish how many people got tested. So out of those 15,600 individuals, about 27% had ever had any coronary assessment, which is pretty bad. The guidelines suggest everybody should have this, but it's actually not that much worse than commercial payers, where the findings suggest only 35% of people actually ever get testing. And then the second part was to understand what does this testing mean, and are there any disparities in who's getting testing? So when we excluded those who had testing previously, only 18% got tested after their heart failure diagnosis, and at a median 25 days after their diagnosis. Now, looking here in the middle, you can see this table. I just kind of condensed it so that you can see, if you look at these relative testing arrows, the older you are, the higher your risk of coronary disease, but the less likely you are to get testing. Women are also less likely to get testing. And then there are some interesting differences by race and ethnicity. Really no significant difference at all between Black or African-American participants and whites, but higher rates of testing among those who identify as Hispanic or Latino or Asian. And then surprisingly, those with diabetes were less likely to get tested, even though diabetes is a potent risk factor for coronary artery disease. Those with hypertension were more likely to get tested. Those with chronic kidney disease, again, chronic kidney disease is interesting because it increases the risk of heart disease significantly in ischemic cardiomyopathy specifically, but it also does increase the risks of some forms of testing. So that might be something where we might not expect as big of an effect. And then smoking was identified as a risk, increased risk of, or increased likelihood of getting testing, which is good because smoking is a risk factor for coronary disease. And then surprisingly, opioid use was associated with a lower relative rate of testing. Now, so then the next thing after we identified these disparities was, well, do they matter? Should people get tested? So what we did here is we designed a target trial where we imagined, what if we randomize people to get testing or not? And so in order to do that, we tried to exclude people with known coronary disease, people with other things, reasons why we might not want to test them, like metastatic cancer or liver disease. And then we used propensity scores to basically pair people up by likelihood of being tested, so that we could eliminate some of these disparities in testing what the effect is. And what we found is that testing within 30 days after heart failure diagnosis was associated with a 19% reduction in mortality. And then testing anytime was associated with a 34% reduction in mortality. Now, if we just look at 1-year mortality, you can see similar results. Those who were tested within 30 days had 6.4% rate of mortality versus 15.2% among those not tested. Similarly, when we look at those tested within 1 year, 5.1% mortality among those tested versus those not tested within the first year of almost 16%. So what's causing that? We did sensitivity analyses, looked at heart failure with reduced ejection fraction versus preserved ejection fraction. No differences there in the effect. We looked at those who are hospitalized for heart failure versus not hospitalized. And again, no differences there.
1 minute warning.
We looked at those who were referred specifically for heart failure workup as opposed to angina or other indications for this kind of testing versus all testing. Again, similar results. So what could this be due to? It could be due to selection bias. Maybe the people who complete their coronary testing are the people who are going to take their medicines and do better. Maybe it has to do with medical therapy. Maybe their medical therapy is optimized. And then maybe it has to do with revascularization. Maybe if we find ischemic cardiomyopathy and send those patients for CABG or PCI, maybe they have better outcomes. So we still have a lot of work to do to figure out how this works, why there's an improvement in mortality. But it is potentially an area where we could do better in terms of reducing disparities and improving outcomes for our patients with heart failure. Thank you.
Thank you. Next, we have Edna Esquer. I apologize again. The Association of Health Behaviors and Metabolic Syndrome Among Hispanic Women.
Sure.
Please put your questions for Dr. Dursensfeld in the chat.
Do they have my poster, Brian? Well, I'm ready. Hello, thank you for the opportunity to be here. I'm Edna Esquer, PhD family nurse practitioner with the postdoctoral fellowship from the National Clinician Scholar Program here at University of California, San Francisco. So today I will be sharing with you some of my dissertation research, looking at the associations of chronic stress and social support in Hispanic women. So according to some CDC data, 25% of Mexican American women have metabolic syndrome in the US. So our specific aims were to describe and to explore the associations of chronic stress, social support, health behaviors, and the presence of metabolic syndrome in Hispanic women living in an underserved community. So for our methods, we completed a retrospective EMR cohort. Our setting was Imperial County, the city of Calexico, which is part of the US-California border. Our sample size, we targeted 150 women. Our inclusion criteria, we had women between the ages of 35 to 55. They were Imperial County community members, and of course, they needed to have initial wellness case data. For some of the measurements, we use the ATP3 guidelines to identify metabolic syndrome. We had a chronic stress burden scale, we did social support instrument, and also we were able to use the staying health assessment to measure health behaviors. So for our results, we were able to target 150 women. Of those 150, 57% met metabolic syndrome criteria. Of the entire sample, 90% of them had a BMI more than 30. So you can see the association of obesity leading to metabolic syndrome. And then in the bottom, you can see the markers for metabolic syndrome with an elevated waist circumference, elevated systolic blood pressure, triglycerides, impaired fasting glucose. So eventually, if we don't do anything about it, it's gonna turn into diabetes. So our main study variables, you can see here in this slide, we completed a bivariate analysis comparing patients with metabolic syndrome and without the syndrome, and we found significant mean differences in chronic stress with the odds ratio 1.6. For social support, no differences were identified. For physical inactivity on patients with metabolic syndrome, 67% responded not doing any exercise. 45% were not engaged in eating a healthy diet, and 54% were limited to food access. So here we can clearly see the social determinants of health in this population. So for our conclusions from our study, metabolic prevalence in this study was 2 times higher than national rate. We had 57%, CDC says 25%, obesity leading metabolic risk factors by far. Social support was high among our population. 87% scored moderate to chronic stress. Metabolic syndrome increased to 26% for each increase in the number of chronic stressors. And comparing other studies, chronic stress was higher in our study versus other studies that we found. So for research implications, we know that we need to be able to start intervention right away in this population with culturally effective strategies for weight management. Metabolic risk reduction is essential among this group. Also, screening for chronic stress and metabolic syndrome should be a priority in their primary care clinics. Short effective strategies to improve coping with stress, and also community engagement. It's a big
minute warning.
In improving health behaviors, and also be able to implement programs that are conducive for this population with safe exercise options, messaging about nutrition and health, and improving access to fresh produce. So we know that food insecurity can be a big challenge among this population. Even though we're in an agricultural town, it becomes our challenge for our population. So thank you. And if you have any questions, I'll be happy to answer. Thanks.
Thank you very much. Next, we have Madeline Sijanga, examining differences in hypertension self-care behaviors among older and younger adults with uncontrolled blood pressure.
Great. Good morning, everyone. Before I start, I'd like to first thank everyone for this opportunity to present my team's findings from our research study. So while uncontrolled hypertension is a chronic disease known to lead to severe health complications, only 24% of the US population report having their blood pressure under control. Thus, hypertension management practices are becoming increasingly important to promote, with evidence-based guidelines suggesting that lifestyle modifications are critical to doing so. Our pilot study aims to understand the impact of having health coaches support lifestyle change goals on reduction of blood pressure among hypertensive adults. Our pilot used a randomized controlled trial design, enrolling 124 adults aged 18 to 85 in Alameda County with uncontrolled hypertension, and randomizing them into 2 arms. Arm 1, where participants received health coaching from students and used self-monitoring of blood pressure, or Arm 2, where participants received apps and handouts containing general lifestyle information. We recorded blood pressure, lifestyle behaviors, and other general health information at baseline, 6 months, and 9 months. Specifically, we evaluated their self-care behaviors through 24 survey questions drawn from the self-care of hypertension inventory scale, which encompassed the self-care maintenance subscale, the self-care management subscale, and the self-care confidence subscale. In these questions, participants answered how likely they were to engage in these self-care behaviors from a scale of 1 to 4, with 1 indicating unlikely and 4 being very likely to engage. Each of the subscale scores were summed and standardized 0 to 100%, with higher scores indicating better self-care. One of our areas of interest was whether self-care behaviors differed by age. Thus, we performed an analysis of self-care scores reported at baseline and 6 months, stratifying participants into 2 age groups, age 65 and above and below 65. And we chose this as a cutoff as people age 65 and older are eligible for Medicare, which we felt could be a contributing factor in behavior differences. We ran unpaired t-tests comparing the scores of each subscale between the 2 age groups at baseline, finding that there was a significant difference at a 95% confidence level between the means of each score, with older adults having higher scores across all subscales than younger adults, as you can see in the table in the middle. This shows that older adults were more likely to adhere to hypertension management behaviors and use recommended actions to lower their blood pressure than younger adults, as well as have a higher perceived confidence in engaging in these self-care behaviors. Now, examining our data following 6 months of intervention, we performed a chi-square test for low-salt dietary behaviors between older and younger adults at baseline and 6 months, comparing prevalence of participants who answered frequent or daily to the prevalence of those who answered sometimes or never to the question, how routinely do you eat a low-salt diet? And what we found was that while there was no significant difference in the likelihood between older and younger adults from both Arm 1 and Arm 2 at baseline, there was a significant difference between the 2 age groups in only the Arm 1 cohort at 6 months, with older adults again having a higher likelihood of routinely eating a low-salt diet, as you can see in the bar graph on the right. Thus, from this analysis, we can see that after 6 months of student health coaching and self-monitoring blood pressure, older adults were significantly more likely to routinely eat a low-salt diet than younger adults. And our next steps will be to examine these self-care behaviors and their potential shift at 9 months. Overall, from these results, we can conclude that because self-care behaviors differ significantly between younger and older participants, medical intervention must incorporate an awareness of possible associations between age and self-care behaviors when assessing adherence risk and strategies for influencing hypertension-based behavior change. And thank you all for this time to discuss our findings. Before ending, I'd like to thank our team, Dr. Susan Ivy, Emily Pham, Morgan Vian, Brandon Chai, Priyanshu Sharma, and Edith Baca for everyone's help and support throughout the study and poster presentation. I would also like to extend a big thank you to our founder, the Dr. Jeffrey Thomas Stroke Shield Foundation. Thank you again, and I welcome any questions.
Thank you. Questions in the chat, please. I would say one personal thing, which is I really appreciate the fact that you made under 65 younger. I really love that. All right. Next presenter, Kendra Sims. Associations of Neighborhood Disinvestment and Gentrification with Hypertensive Risk, the Health and Retirement Study.
I don't see Kendra present. Kendra, are you here?
All right, let's move on. And if she comes back, we can have her come present. The next presenter, sorry, Carolyn, we have to put you up next. Carolyn Zhu, Observation of Lifestyle Behavioral Differences among men and women with high blood pressure.
Hi everyone, my name is Caroline and I'm here to present on the observations of lifestyle behavior differences between men and women with high blood pressure. So as a background, according to the CDC, hypertension is quite prevalent in the United States, with nearly half of the adult population having hypertension, but only 25% of those who are diagnosed having blood pressure under control. According to organizations like the American Heart Association, it's been recommended that evidence-based lifestyle changes, including low-salt diet, eating more fruits and vegetables, and exercising regularly can help manage this. Additionally, further studies have found that self-measured blood pressure monitoring, or SMBP, have been found to be effective for the better control of blood pressure. So in our study, which is a randomized control pilot, we looked at the effectiveness of health coaching, which involves motivational interviewing as well, in addition to SMBP, could be effective in comparison to just receiving general health information on lowering blood pressure. Throughout the study, we recruited individuals with high blood pressure between ages of 18 to 85 from Alameda County, and they were randomized into two arms, the first arm being receiving undergraduate health coaching with SMBP, and the arm two being receiving information through general pamphlets or applications to manage blood pressure. So at the start of the study, we collected data at baseline, and this was continued at 6 months and 9 months. In these surveys, we collected information regarding their living situation, age, gender, lifestyle choices, and other health data. So throughout the study, to examine differences specifically between men and women, we stratified the baseline data to create a woman group of 68 individuals and a man group including 54 individuals. We performed an unpaired t-test between many of these lifestyle variables, and we found that in terms of physical exercise per day between the two groups, we found that more men exercise per day than women. So men on average exercise around 72.9 minutes per day and women exercise around 45.6 minutes. We also performed a 2-sample Z proportion test and found that more women lived alone than men. We also, just for further exploration, performed these similar tests on 6-month data set. We found that in the arm 1 participants, similar trends were seen in which more men exercised per day than women and more women lived alone. Other lifestyle behaviors, including salt consumption and fruit consumption, were not significantly different. So in conclusion, we found that overall minutes of physical exercise per day and living situation differ significantly between men and women at baseline, and more women lived alone and were likely to report lower physical exercise in minutes per day than men. There can be many implications of this trend. There could be potential gender-related disparities between living situation and physical exercise levels. And there is also a possibility that living situations could also impact physical exercise levels. So overall, living alone, this suggests that living alone may be a significant challenge to blood pressure management due to perhaps a lack of social support for implementing lifestyle changes such as physical exercise. Existing literature also suggests that more older women live alone, so understanding the relationship between gender, age, and lifestyle behaviors can be really important to target future programs to reduce these health disparities. Especially also considering the COVID-19 pandemic, there's been a sharp reduction in social interactions, which may have exacerbated existing health disparities and definitely weakened support systems, increased isolation, other factors that may be disproportionately impacting women. So since our
1-minute warning
in process, we plan on analyzing these factors further at 9-month data and also seeing if these trends directly impact blood pressure levels. Thank you. Oh, and also before I end, I'd also like to thank our sponsor, which is the Jeffrey Thomas Strokes Shield Foundation, as well as the rest of the team in supporting this project. Thank you.
Thank you. Has Kendra come in yet, Ryan?
I don't see Kendra.
Okay, great. All right. Now next, Colin Roach on racial disparities in care among out-of-hospital cardiac arrest patients.
Hi, everyone. I'm Colin, a third-year medical student at UCSF, and I'm here to talk today about racial disparities in care among out-of-hospital cardiac arrests and the theoretical benefit of an ECPR program to improve outcomes. So over 350,000 out-of-hospital cardiac arrests occur every year, with survival as low as 7%. Non-white patients exhibit a higher incidence receive inferior care and are more likely to have a poor outcome. ECPR is an advanced, increasingly utilized method of resuscitation. It utilizes a heart-lung bypass, facilitating cerebral perfusion and transfer to the cath lab. And evidence supporting its use is continuing to mount, including recently randomized controlled trials. The objectives of our study was to assess whether there are similar racial disparities here in San Francisco County in process of care metrics, primarily coronary angiography, as well as in outcomes. We wanted to identify ECPR candidates in the pre-hospital setting. And then we wanted to see where these patients are being transported to and determine whether a single center receives a plurality of candidates and could theoretically be an ECPR center in the future. If so, we'd want to zoom in on that center, on the theoretical center, and assess how these candidates are doing without ECPR. So across 6 years, we identified a little under 4,000 patients and found that Black patients were overrepresented in out-of-hospital cardiac arrests. Though they are 6% of the population, they are 13.3% of out-of-hospital cardiac arrests with a presumed cardiac etiology. Patients with documented Black, Latinx, or Pacific Islander ethnicities were less likely to receive emergent angiography and more likely to have an unfavorable neurological outcome. Then we looked at the subpopulation that was found to meet ECPR criteria. This was based primarily off of age, whether it was a witnessed cardiac arrest, if they got bystander CPR, and the initial rhythm. We found that 502 patients met this preliminary ECPR criteria. And in terms of differences between subgroups, the only statistically significant difference was age, where Black patients were 5 years younger than their white counterparts. We found absolute differences in process of care metrics as well as outcomes, but these did not reach statistical significance. So of these patients who were transported to an emergency department, we looked at which STEMI receiving hospitals they were sent to. And the center that receives more, the STEMI center that received more than all others combined was the level 1 trauma center, which is indicated with the orange portion of the pie chart. On the top right, we have a map of where these ECPR candidates, where the cardiac arrests were occurring in the city. And as you can see, it was primarily in the south and east part of the city. And coincidentally, the level 1 trauma center is well situated in close proximity to many of these arrests. So because this level 1 trauma center is already receiving a plurality of ECPR candidates, and because of its location, we thought that this would be an ideal theoretical ECPR center. Then we zoomed in on hospital level data of this center and looked at all coming cardiac arrests across a year and a half. We went through 250 cardiac arrests and then used similar inclusion criteria to definitively rule patients in or out of whether or not they meet criteria for ECPR, but did not receive it because we do not have a program. Black patients were also overrepresented in this population. You can see that they were 39% of ECPR candidates at this single center. Now, in terms of how they did without ECPR, of the 28 patients who were identified as candidates, 4 survived to hospital admission. Of those 4, 75% had suffered a severe anoxic brain injury, and none survived to hospital discharge. So in conclusion, patients identifying as Black or African American were overrepresented among all out-of-hospital cardiac arrests, as well as ECPR candidates. Racial minorities were less likely to receive angiography. And a plurality of ECPR candidates were transferred to the level 1 trauma center and safety net hospital. There, 28 patients met definitive ECPR criteria and none survived to hospital discharge. Some interesting incidental findings about this study was that our level 1 trauma
warning
happened to receive the most ECPR candidates, but it turns out the American College of Surgeons already recommends that level 1 trauma centers have 24/7 bypass capabilities, suggesting that it would be cost effective to co-locate the ECPR center at a level 1 trauma center. It's also a safety net hospital, meaning it captures large groups of patients who are currently exhibiting or receiving inferior care, suggesting it may be a viable place-based health equity initiative. I'm interested in repeating this research on a larger scale since many of our results were not statistically significant. And there are 7 other centers in California who are level 1 trauma centers, academic centers, as well as safety net hospitals. And so if anyone's interested in collaborating to help do this correctly, please send me a chat. Thank you. Welcome any questions.
Thank you. Thank you very much. First of all, let's give all of our presenter a hand, whether it's verbal, visual, emoji, whatever. Awesome work. Really, actually, really interesting set of questions, approaches, and findings. If you have questions for the presenter, please raise your hand. But I want to start with a question for everyone, and keeping in the theme of today, knowing what you know, what would be the intervention that you would do to address the disparities that you saw? It could be an individual intervention, it could be a system intervention, it could be a policy intervention. Let's think about making change, given what you know, but also what you want, because obviously sometimes the data isn't going to be quite ready for that step yet. So we'll just walk down the list of presenters. Is Victor still on? I think
Victor had to leave
Victor had to leave
for retreat. Yeah.
Okay. Matthew seems to not be on. All right. Edna.
Yes. Yes, thank you. Thank you for that question. But yeah, going back to chronic stress and metabolic syndrome in Hispanic women, I think it becomes very important to start doing more community engagement, but community participatory research, getting the population involved, also talking to stakeholders locally. And Imperial County, we're in the US-Mexico border. So we have people that work in the US, live in Mexico. So the dynamics are hard to follow. But of course, we have to do binational programs and start intervention at that level. So incorporating the healthcare system, the local clinics, help programs with Mexico to see what would be more successful among this population. But definitely there's time, this is important, and specifically for implementation science, that we gotta start doing some intervention that is appropriate for this population.
Thanks, Edna. Madeline?
Yeah, no, that's a great question. I think just from the perspective of our study, with the background that chronic diseases like hypertension are heavily influenced by lifestyle factors, not only increasing education surrounding these factors, but also giving these patients the tools they need to be able to make these lifestyle changes is really important. So referring back to our study, one thing that we do involve for student health coaching is motivational interviewing. So really just giving them the motivation, but also like different lifestyle strategies for them to be able to make these changes. So that's something that I believe, and the rest, and what our study is based off, is really important for improving on these disparities.
Yeah, I love the concept of student health coaching because the intervention goes both ways. It goes on the student and on the patient, right? So that's awesome. All right, Carolyn.
Yeah, thank you for the question. So as Maddie mentioned, so if you guys haven't realized, we're in the same study. And yeah, it's been really great to have undergraduates participate in motivational interviewing. So as our poster has suggested, there may be some association between individuals living in isolation, specifically women, and being able to implement lifestyle changes such as physical exercise. So I think adding on to what Maddie said in continuing motivational interviewing programs, we could also increase community outreach to target perhaps senior centers and older individuals, as well as trying to reach those individuals living in isolation and giving them support through motivational interviewing.
Really like that because you got both an individual intervention on the student coaching and then maybe a more systematic intervention in terms of how to address social isolation. Awesome. Thank you. Colin?
Yeah, I think with the out-of-hospital cardiac arrests, there's upstream and there's downstream interventions. In a perfect world, we'd prevent certain patients from having higher levels of cardiovascular disease and prevent the occurrence of out-of-hospital cardiac arrests. But I think that we can also work on improving care for if and when these patients suffer from higher rates of out-of-hospital cardiac arrests. And I know that ECPR is quite the costly intervention, but it's something that is becoming increasingly popular. So I'm hoping it could potentially be used as a tool to combat things that we see in our system that we disagree with.
Thank you. Susan, you have your hand up?
I was just sending Edna a question because I wasn't sure we'd have time, but just asking Edna about your study of the women looking at allostatic load and other chronic stress types of measures. Did you also measure discrimination or racism or anything like that?
This was a small retrospective study of 150 women. So most of our women, they were part of this community clinic. So we didn't ask that, but see here in the US-Mexico border, we see different dynamics when it comes to immigration challenges. Right. So we are an agricultural town. So most of our population, they live in Mexico, Mexicali, they work in the US. So of course it becomes a challenge, but definitely we need to look into that too.
Great, thank you.
Right. So I think sort of the implication, I don't want to speak for Susan, but when we talk about chronic stress, there are causes of chronic stress. Like, so when you look at association between whatever factors is that you're doing, you can also look at the association between whatever factors you're looking at to sort of structural determinants, right? So, and then when you're thinking about which intervention you're going to do, you get to think about that, like you intervene on the individual or on the structural stuff, right? So, other questions? All right. If there's no other question, we might finish early, but I'm going to actually ask everyone in the room then to participate by giving the presenter interventional ideas. Like, given what they've said, what would you say to them about, hey, you got to think about this next project or the project after or the project 5 years from now. This is what you should be doing to address the question you're so interested in. I want to actually start with Brian because he's been kind of quiet. Is there anything of any of these projects that you want to tell them, this is what I think you should be doing?
I'm not sure I'm qualified. I mean, these presentations were very...
Okay. First of all, do not say that. Community engagement means the community, people living in the community have as much of an idea as how to intervene as others. So
absolutely.
You don't, I'm just putting you on the spot, Brian. You don't have to.
No, I think definitely looking ahead, community engagement, I think education is a huge thing. Speaking for myself, being an immigrant to the US, and kind of trying to navigate the healthcare system, I think in retrospect, I noticed that there's a lot of a lack of information, or sometimes can I actually do that because will that somehow violate my immigration status or something? So kind of like accessible information and making it more digestible. I think that's just one thing that I'm really, really big on.
Thanks. Presenters are welcome to comment on other presenters' interventions.
This is Susan. I can say for our study, I know one of our workers, Edith, is on that the importance of making our intervention, transferable for other populations. In the case of some of our students starting to work in Spanish and be able to practice motivational interviewing in Spanish, not just have somebody say in English, here's what you do, but actually have time together as a team to start practicing those skills. And again, as Tung was saying, for undergraduate students, even to recognize how important this skill is, because it can be used in many different health careers in the future, not just in medicine, but counseling, physical therapy, other nursing careers, nurse practitioners, PAs, et cetera. So I think it's just a critical skill for undergrads to at least learn about, but it takes practice to really get good at that skill. And I think it's a lifelong skill that people can use out in their communities. So hopeful.
Yeah, I really applaud that. Actually, when we think about a lot of the problems that we're dealing in society in terms of how divided we are, even when it comes to things like vaccination and science, you despair of how to change people's thoughts and their behaviors. And telling people what to do has never worked all that great. So I think the technique of motivational interviewing, getting people to the point where they understand their own motivation and why they're acting against themselves and their goals is really the way to go. So if I had to teach somebody a set of skill to make change in the world, that is the one. So thank you, Susan. Edith, you have your hand up?
Yeah, and if I can add to what Susan was saying, once we have the materials translated, for example, from English to Spanish, it also takes a different set of skills to understand what that person is talking about, because they're at a much different level educational wise, to the point where we had special meetings in which we just discussed how are we going to talk to this person that asked us about race. What does it mean to be Native American or Mexican American, or even to that level, to explain the different concepts. So,
Yeah, I agree with that, and I actually will say too that motivational interviewing isn't a one-way street. In other words, there's no neutral person doing the motivational interviewing, right? So it's how you do the motivational interviewing depends on who you are, and like as a physician or whoever, and so that also speaks to the need for workforce diversity, right? So
Exactly.
I mean, I am able to interview a Vietnamese patient much better than I can interview a non-Vietnamese patient because I know some of the common buttons or common background issues where I can use it to prompt people to think about things. So, absolutely. All right. Other people. I'm not going to call on anyone but I also encourage you to speak up. Morgan's got hand up.
Oh,
Sorry, and Morgan first, and then Edna.
Yes.
Okay, sounds good. Yeah, also wanted to agree what was just said by Susan, Edith, and Tung, and the importance of racial and language concordance when partnering with individuals in the community to ensure that, as we said, it goes both ways, that the health coach can provide information and the community member can give feedback on if it's working, if they need something that they need help understanding, if they have any concerns, perspectives or opinions about certain recommendations that the health coach can help explain. So I see this in the study that we're in with the health coaching and hypertension, but also out in the community and among my family, how important it is to have a medical professional or a community health advocate really show what's the health benefit and why we're doing this for the individuals in the community.
Thank you. Edna.
To comment on what he was saying on workforce diversity, there's a disparity right there. And when you are working with someone that is limited English proficiency, the literacy level becomes so important. So when we're developing our instruments, it's so important to run it to the community that we're engaged with, but it's all about engaging with them and addressing their needs. Because what it works in San Diego, it might not work in Imperial County, even though you're working with Mexican American, different ways of doing things. So yes.
Thank you. Last thoughts or comments? Thank you to I see some mentors in here, so I appreciate, thank you all for creating the opportunity for your trainees to do this. So, thank you so much for participating. Thank you for your science. Thank you for your community, because I think the other thing that we really care about the symposium is that sometimes this work can be a little lonely, and we need support. And thank you for supporting all of us. Take care. Hope you submit again.
Hopefully next year in person, right?
Yes, no, we're gonna push for Brian's gonna be the one who has to deal with this, but he's smiling, which means it's a good time.
Definitely, that's the plan, in person next year.
All right. Thank you, everybody.
All right.
Bye-bye.